Hello everyone, I'm Anas Al-Ubaidi, and the topic or the title for this session is Rheumatological Conditions and Workflow Practices within Chapter 31 or 31st, which is about review of endocrinology and rheumatology scribing within the Certified Medical Administrative Assistant course program by ACMSO. Introduction. Rheumatological conditions encompass a broad spectrum of disorders affecting joints, connective tissue, and the immune system. These conditions include autoimmune diseases like rheumatoid arthritis, or RA for short, and lupus, degenerative diseases such as osteoarthritis, and other disorders including gout and vasculitis. Recognizing and effectively documenting these conditions is vital in providing comprehensive and coordinated patient care, as these diseases often involve multiple systems and demand a multidisciplinary approach. For the advanced medical scribe, understanding rheumatology is not just about learning the conditions themselves, but mastering the workflow practices that streamline documentation, from capturing the patient's history to summarizing diagnostic, treatment, and follow-up information clearly and accurately. The complexity of rheumatological diseases can lead to symptoms overlapping with other specialties like neurology, cardiology, or dermatology. So scribes need strong attention to detail to track disease progress, medication regimens, and patient-reported outcomes. Furthermore, these debilitating conditions often lead to long-term management plans requiring thorough and structured documentation to ensure continuity of care. Key points. Comprehensive understanding of rheumatological conditions, differentiating chronic and acute conditions. Rheumatological conditions can present as either chronic, requiring long-term management, or acute episodes demanding urgent care. Proper documentation of their characteristics, progression, and systemic effects is essential to ensure effective treatment. Chronic conditions. RA rheumatoid arthritis presents as symmetrical joint inflammation characterized by morning stiffness and progressive deformity. Its impacts include systemic complications such as fatigue, anemia, and cardiovascular concerns. Chronic management involves tracking symptoms over time with tools like joint counts, swelling patterns, and DAS-28 scores, which is short for Disease Activity Score for 28 joints. SLE, which is short for systemic lupus erythematosus, is a multi-system autoimmune disorder. Key manifestations include arthritis, photosensitive rash, renal or kidney involvement, lupus is called lupus nephritis, and neurological symptoms. Accurate chronic documentation highlights the impact on specific organs and tracks treatment efficacy through laboratory markers like anti-double-stranded DNA and complement levels. Acute disorders. Gout manifests as sudden severe joint pain, most commonly in the big toe, along with the redness and inflammation. Documenting uric acid levels and joint aspirations for crystal identification ensures targeted treatment. Acute septic arthritis escalates rapidly with intense joint pain and fever. Immediate notes on joint aspiration, antibiotic treatment, and follow-up imaging reassure appropriate management. Example. A patient with chronic RA rheumatoid arthritis displays worsening hand deformities and reports morning stiffness exceeding 1 hour. Documentation includes annual X-ray reports of joint erosion alongside inflammatory marker trends, ensuring medication adjustments are evidence-based. And here we have a diagram showing the chronic rheumatological conditions. As on the left, we have the SLE, when on the right, RA. Systemic manifestations and multidisciplinary documentation. Many rheumatological diseases extend beyond the musculoskeletal system, requiring careful coordination and documentation across specialties. Systemic vasculitis conditions like giant cell arteritis involve blood vessel inflammation, with symptoms ranging from jaw claudication to vision loss. Complementary specialty notes from ophthalmologists, eye doctors, and neurologists should be interlinked to inform treatment plans. Skin manifestations, psoriatic arthritis documentation often requires dermal examination notes describing plaques and their correlation with joint symptoms. Renal, kidney, and cardiopulmonary overlaps. As SLE, systemic lupus erythematosus often involves lupus nephritis manifesting as proteinuria or hematuria blood in the urine, documenting renal, kidney biopsy results, alongside systemic symptoms like pericarditis, ensures every specialty stays synchronized. The skill to extract relevant details across disciplines and present them concisely empowers scribes to optimize clinician workflows. Example: in an SLE patient with concurrent nephritis, documentation integrates nephrologist prescriptions of immunosuppressants and rheumatologist guidance or corticosteroid tapering. Key diagnostic markers and imaging insights. Diagnostics form the basis of effective rheumatology documentation by confirming conditions and tracking disease progress. Autoimmune markers, antibodies such as ANA and anti-CCP play a critical role in diagnosis. For example, while ANA positive is highly sensitive for SLE, anti-CCP is far more specific for RA rheumatoid arthritis. Inflammation markers, trends in ESR and CRP monitor disease activity. Scribes must track these values longitudinally to observe responses to treatment, particularly in chronic inflammatory conditions like polymyalgia rheumatica. Synovial fluid analysis, essential for conditions like gout and septic arthritis. This test identifies uric acid crystals or infections, documenting fluid characteristics, for example, clarity, cell count, provides a quick, clear summary for clinicians. Imaging tools, radiographic evidence such as the bumbo spine and ankylosing spondylitis or erosive changes in RA rheumatoid arthritis supports clinical findings. Scribes should prioritize including radiologist interpretations and medical notes for a holistic patient view. Example, a patient with suspected RA rheumatoid arthritis undergoes anti-CCP testing and hand X-rays documentation notes positive antibody results alongside early erosive changes consistent with RA rheumatoid arthritis diagnosis. Treatment documentation, medication, and medication management. Rheumatology treatments often involve disease-modifying medications that require vigilant tracking to prevent complications. Medications, DMARDs, for example, methotrexate, are central to RA rheumatoid arthritis management, but demand frequent liver enzyme checks to monitor hepatotoxicity or liver toxicity. Biologics like adalimumab reduce inflammation but predispose patient to infections, requiring routine TB, tuberculosis, and hepatitis screens documented by scribes. This is about adalimumab. So for methotrexate, liver enzymes screen or continuous regular check required with methotrexate, but with adalimumab, because of infection risk, high infection risk within a patient taking or prescribing was prescribed continuously with long-term or chronic use of adalimumab, then screening for or checking for TB, tuberculosis, and hepatitis required. Corticosteroids or steroids mitigate acute flare-ups but require tapering plans to minimize withdrawal effects. In case a patient was on steroid or corticosteroids and we decided to, or the provider or the clinician decided to stop the patient from taking corticosteroids, then tapering, meaning minimizing it or reducing it gradually till it is stopped completely. Non-medication interventions, physical therapy, dietary advice, for example, low pre-urine intake for gout, and patient education are integral for comprehensive management. Documenting compliance improves healthcare outcomes. Example, in an RA rheumatoid arthritis patient prescribed methotrexate. Follow-up notes include recent liver enzyme trends and vaccination records to identify any risks associated with treatment. And here is a diagram summarizing the comprehensive management of RA rheumatoid arthritis patients. Follow-up documentation and outcome tracking. Successful rheumatological care depends On regular follow-ups and clear tracking of outcomes, advanced scribes play a pivotal role in ensuring continuity of care. Key parameters to monitor joint function and symptom trends using standardized scoring systems, like the DAS-28, help evaluate RA rheumatoid arthritis outcomes effectively. Renal or kidney and respiratory parameters are vital in systemic conditions like SLE to manage organ involvement proactively. Adverse events, thorough documentation of side effects. During medication reviews, for example, weight gain with corticosteroid or evoked flares on tapering DMARDs aids swift adjustments. Coordination with a specialist, collaboration between rheumatology, dermatology, cardiology, and other specialties ensures every aspect of the patient's condition is covered. Summarized referrals and shared workflows are critical to maintaining accuracy. Example, for a gout patient with recurrent flares, documentation includes time-logged uric acid levels, dietary compliance summaries, and rheumatologist prescribed medication adjustments. Next, we have summary tables. Here we have table on common rheumatological conditions and their symptoms, table on diagnostic tests specific to rheumatological conditions, table on typical medications prescribed in rheumatology, table on monitoring and follow-up practices, table on workflow practices specific to rheumatology documentation. Next, we will revise what we have covered via this lecture through some MCQs or multiple choice questions. Question 1. Which of the following is a hallmark symptom of rheumatoid arthritis, RA? Is it A, episodic unilateral joint pain, B, morning stiffness lasting more than 30 minutes, C, sharp back pain relieved by rest, or D, diffuse muscle weakness? Definitely it's B, the morning stiffness. As morning stiffness is a distinctive symptom of RA, often lasting longer than 30 minutes, it is associated with joint inflammation. Unilateral joint pain is more common in conditions like osteoarthritis or gout, while sharp back pain relieved by rest and diffuse muscle weakness suggested other conditions like ankylosing spondylitis or myopathy. Question 2. What diagnostic test is highly specific for rheumatoid arthritis, RA? Means a diagnostic test for it, for RA. Is it AESR, B, ANA test, C, anti-CCP test, or D, RF test? So all of them might be positive, most likely will be positive test with RA rheumatoid arthritis. However, ESR is positive in RA as it is positive in any other cases. ANA is positive in RA as it is positive in any other conditions like SLE will have ANA positive as well. RF will be positive with RA rheumatoid arthritis or any rheumatoid disease similar to RA rheumatoid arthritis. However, C, anti-cyclic citrullinated peptide, anti-CCP, is particularly positive that's why it's considered a diagnostic test for RA rheumatoid arthritis. So the answer is C, as anti-CCP antibodies are highly specific for RA and are present in the early stages of the disease. While RF is also seen in RA, it is less specific and can appear in other conditions. ESR and ANA are general tests for inflammation and autoimmune activity, respectively, but not specific, not as a diagnostic test to or for RA rheumatoid arthritis. Question 3. A patient with systemic lupus erythematosus, SLE, presents with dark urine and swelling in the lower extremities. What should the scribe include in follow-up planning documentation? Is it A, referral for joint imaging, B, history of recent infections, C, renal function tests, such as serum creatinine and urine analysis, or D, check for uric acid levels? Definitely it's C, about urine, about kidneys, about the renal system. So these symptoms suggest possible lupus nephritis, which is a common complication of SLE. Renal function monitoring, including serum creatinine and urine analysis for proteinuria or hematuria, is essential. Joint imaging and uric acid levels are less relevant in this scenario, while infection history is secondary. Question 4. What is the main reason for regular monitoring of liver function tests, LFTs, in rheumatoid arthritis patients taking methotrexate? As we said earlier through the prior slides in this session, that in this video or in this session, that patients on methotrexate will be monitored regularly to check their liver function tests. Why? In order to avoid um, or check for any possibility or risk for hepatotoxicity or liver toxicity. Now, A, to detect early signs of organ failure, B, to track methotrexate's effect on inflammation, C, to screen for autoimmune hepatitis, or D, to monitor for hepatotoxicity caused by the medication. So D is the answer. As methotrexate can cause liver toxicity, making liver function tests essential for ongoing monitoring in RA patients taking this drug. Early screening helps prevent complications. The inflammation tracking role belongs to inflammatory markers like ESR or CRP. And autoimmune hepatitis is unrelated to methotrexate. Same as patient again with on adalimumab, screening them or such patient for TB and hepatitis. Question 5. Which workflow practice is most effective in improving the efficiency of documentation for rheumatological conditions? A. Documenting all details of the patient's history manually. B. Using structured templates for system tracking and review. C. Relying solely on referral letters for previous diagnostic tests. Or D. Delaying final notes until all test results are available. Definitely it's C. Structured templates. Definitely is B, as structured templates. So using structured templates for symptom tracking and review. So B is the answer. So a structured template streamline the documentation process by ensuring all relevant information about symptoms, lab trends, and treatment plans is consistently recorded. Manual documentation is time-consuming and inefficient. Referral letters provide important context but are insufficient as a primary resource. Delaying notes disrupts workflow and continuity of care. And here we come to the end of this lecture. Thank you very much and goodbye.